طيب، بسم الله الرحمن الرحيم. حياكم الله جميعا. صراحة أنا جدا سعيد أني اليوم أقدم السب سبيشاليتي ليكتشر. أتمنى إن شاء الله بإذن الله تكون جدا مفيدة لكم وتستفيدون منها. طبعا اليوم بتكلم عن الريفراكتيف سيرجري. Mainly I'm going to speak about يعني major concept. The idea of presenting this lecture is to clarify the basic concept of refractive surgeries. It might be a little bit of revision to some of you, and the other will inshallah benefit from this clarification of the major concepts. Then I'll speak about wavefront and aberration a little bit. Then we'll speak about patient evaluation and contraindication of refractive surgeries. And then at the end, I'm going to present some of the calculation that I found a little bit useful يعني كده quickly in the clinic to see if a patient will benefit a lot from the refractive surgery, or this patient should not undergo a refractive surgery. Bismillah. Generally speaking, refractive surgery generally it can be based on cornea or based on lens. Either service procedures in cases of incisional procedures such as radial keratotomy, or for example a limbal relaxing incisions. It could be excimer laser as a service ablation مثل PRK, LASIK, EpiLASIK, or a lamellar based excimer laser such as LASIK, femtolasic, or whatever it includes extraction of a lenticule such as SMILE. And sometimes we do a lamellar based procedures but does not involve laser. For example, epikeratofakia, and another example is the corneal rings. Intraocular procedures, either phakic or pseudophakic procedures, such as anterior chamber IOL or iris fixated IOL, posterior chamber phakic IOL, مثل ICL, or sometimes it includes the removal of the lens. An example of that is a clear lens extraction with multifocal accommodating lens, extended depth of focus IOL, or a toric IOL. Today I'm going to speak about the most common refractive surgery, either surface ablation or LASIK. Surface ablation or LASIK, they undergo an ablation profile by the excimer laser. This ablation profile, it could be something that is customized for a specific patient, or something is not customized for the patients. The non-customized ablation profile includes the conventional treatment or Wavefront-optimized ablation. Customized includes Wavefront-guided ablation and a topography-guided. We're going to speak about each one of them in the coming slides. So in general, either we treat excimer laser on the surface with or without the removal of epithelium, and this is a PRK basically. Sometimes we have to do a flap, and then we have to lift the flap and apply the laser on the stroma. This is LASIK. The other example is the lenticule extraction, such as in cases of SMILE. Excimer laser, we're actually using a high voltage electrical charge. The idea of this high voltage electrical charge is to combine the atoms of excited argon and fluoride. Once these two excited molecules becomes together, we call them a dimer. But this dimer actually is not stable, and it tends to go back to its separate atoms. This separation will get us a charged photon. And this is the idea where the name excimer comes from an excited dimers. So basically, we use this separation of the excited atoms of argon and fluorine in order to generate a photon. Photoablation, which is the very precise removal of corneal tissue with a very minimal damage to the adjacent corneal tissue. The cornea as an organ has extremely high absorption coefficient. We're speaking of 193 nanometer. So if we are going to use a single 193 nanometer photons, it should be sufficient energy to break the carbon-carbon and a carbon-nitrogen bonds, which is the backbone of the corneal collagens. The changes that we do in the cornea, in cases of myopia, we tend to flatten the cornea centrally in order to have a lower keratometry reading in the central part of the cornea. So we're flattening the central cornea. But in cases of hyperopia, we're actually steepening the central cornea by removing tissue from the peripheral part of the cornea. And in cases of astigmatism, we actually tend to treat by a cylindrical beam that removes tissue from the steeper meridian, which will be flattened to correct the astigmatism. So this is basically what we mean. In the central part of the cornea, we're removing the central part of the cornea, which will be flattened. And in cases of hypermetropia, we're flattening the peripheral part in order to steepen the central part of the cornea. So this is an electronic microscopy picture of a patient underwent around -4 of myopic ablation. And this is the margin of the central abrasion. And at this level, this is a -6 myopic ablation. And you can see the difference between the area being ablated and the area is not ablated. This is a pathology section of a rabbit cornea, which was immediately examined after excimer laser. And you can see here the defect that happened into the central part of the cornea. This slide was examined around 24 hours after the ablation. And you can see here, the inflammatory cells are getting into the area of the laser treatment. The laser application methods, we used to have a broad beam application excimer laser, which uses a large diameter beams. We're talking about 77 millimeter. It has a very low repetition rate and high energy pulses. The problem of this wide beam that there is a limited area you can do it. You cannot go all the way to the periphery. This is one. And this will lead to uneven ablation. So it will not be as smooth as we want in the peripheral part of the cornea. Then the idea of a scanning slit came with a narrower beam, which improve the smoothness of the ablation. And of course, it tends to give us more room, more space, and a larger treatment zone. The newer generation, which is the flying spots, flying spots actually, it uses a very small beam diameters from 0.5 to 2 millimeters and a very high repetition rate. But of course, they need a very good tracking system in order to do a very precise ablation. This is the different generation over time of the refractive excimer lasers, starting with a broad beam, then moving to the scanning slit, then a flying spots. Then it becomes more advanced technologies where the ablation became faster and very fascinating tracking systems with, of course, an amazing cyclotorsion control. It also allows us to do very minimal high energy pulses. This is a quick comparison between the current machines. And if you can see that most of them are using flying spots and of course with a different spot size, different pulses frequency, and a different tracking systems. So let's move and speak about wavefront and aberrations. As you can see here, any incident light ray usually they come from infinity. There must be parallel to each other. This is 1 and this is 1. And they are consistent of sinusoidal oscillations. So this is one ray, and this is the second one in the sinusoidal fashion. So when we mark a location that show us an equal phase of this wave, what I mean, if we point somewhere here and we take an equal area or a location of a different wave of the total array, this area, we can call it a planar wavefront, okay? These wavefronts are parallel to each other, and they are perpendicular to the direction of the light ray. And this is what we mean by wavefront, basically. So as this wave passes through a refractive surface, if this refractive surface is perfect, they should meet at an exact point. And this is what we call it a focal point, okay? So the real wave front, actually, they deviate from a perfect system. What we mean, as they pass through a refractive surface, they are not as really as we're showing in these paragraphs. They tend to deviate from the perfect plane. Any deviation from the ideal plane, this is what we call it an aberration, okay? So when we measure the difference between actual wave shape and the ideal, then this is what we mean by an aberration. In other words, if we take an ideal wave front and we compare it to a wave front in reality, and we found a difference, so this is what we should call an aberration. The smaller the aberration, of course, the better quality of the refractive system. And the larger the aberration, the larger the pupil size, the larger amount of aberrations we're going to get. This is specifically in cases of low light conditions. This map is actually called the Zernike pyramids, which actually shows us every single aberrations. And in cases of zero aberrations, we mean that there is no aberrations at all. This point, we call it the piston, where there is no aberration, a perfect optical system. And then we have a lower order aberrations and high order aberrations. This map, it is not that complicated. As it looks, actually. We use it within orders and a different frequency in order to study these aberrations, in order to know what kind of aberrations we're dealing with. So lower order aberrations are mainly the refractive errors, specifically the spherocylindrical refractive errors. We're talking about 85% of all aberrations are considered low order aberrations. The good thing about them that they can be corrected with the glasses. We have different types, include tilt, defocus, and astigmatic aberrations. Tilt is actually whenever there is a deviation in the direction where the beam of light propagates. This is usually caused by a decentered optics, which is more or less the prismatic effect. Focus, whenever it's out of the optical axis, but still along that axis from the plane or the best area of the focus along the same plane, then this is a defocus. Of course, you know that myopia is a focal point that lies in front of the retina and hyperopia lies behind the retina. Whenever we have a ray that propagates into two perpendicular planes, then in a different location, this is what we mean by a vertical and horizontal lines, which explains stigmatism. I think this is an easy part now, the low order aberrations. Speaking about the high order aberration, they may or may not be associated with refractive error. That's the first thing. The problem that is they cannot be corrected with classic optics, and this is their challenge. They can result from any disturbance, irregularity, haze, scar, anything. And their impact on vision is worse than the impact of low order aberrations. The most common type of high order aberrations includes coma, trefoil, and spherical aberrations. I'll try to explain each one of them in very simple words. Coma is usually the variation of magnification or the variation of refractive power over the pupil. This will lead to a formation of a comet, or by another word, a tail. So whenever we are having an asymmetrical corneal surface that is caused by a different power along the pupil entrance will induce a coma. So let's see this example. This is a patient who underwent a decentered myopic ablation. And if you assume this is the pupil, if you compare this area, which is very flat area, to this area, which is a little bit steeper area, so we have a difference at the pupil entrance. One part is flat, another part or another side is steep. So this will lead to coma. This is exactly similar to the previous topography. This is a flatter area than this area. If we get a cross section, and we look at it at the pupil level, this part is actually a little bit having a lower refractive power, and this is a little bit higher refractive power. The result of this disparity will be here at this point. It will not be even, and there must be some disparity that will give us the look of this. This is usually we see it in photography. This is the intended point, and this is how we see it. Okay, let's see how the patient seeing it. This is exactly how does the patient see a coma, which is not easy. It is a bit significant. And spherical aberration is actually a peripheral ray that is being bent more strongly in the peripheral area compared to central area. Okay, so this will be getting bended more than this part. So this is a positive aberrations. And negative aberration when the central ray becomes more bended compared to the peripheral part. This is an example of a patient who underwent a hyperopic ablation, and this led to a different corneal power or a disparity between the central part of the cornea and peripheral part of the cornea. And this will let the patient see halos around light. This is exactly how does the patient with a spherical aberration see, especially at the night time. The third type of high order aberration is the trefoil, and it looks like this plant. Exactly. What we mean by the trefoil is actually more or less irregular alternating in the magnification along the different corneal meridian. This is a bit steeper, this is a bit flat, this is steeper, this is a flatter. So we get exactly the same look of the trefoil implant. And this is exactly how the patient sees them. This is exactly how does the patient with a trefoil see the light. There are different measurements of aberrations, different method. Some of them are a little bit complicated, honestly. Some of them are easy to get. One of the things that I feel easy to get at least an idea about aberration, you can order a Zernike map from a Pentacam, for example, It will give you idea about the aberration from the map. And if you feel it's a bit complicated, you can have a look at the root mean square. The root mean square will give you an idea about the aberration in general. You can choose if you want what kind of aberration that you want to look at. For example, if you want to check only the 3 most common aberrations, you can click on them, and then the root mean function will give you an idea how much this is affecting the patient. Usually, if it's more than 0.3, this is considered to be a little bit toward serious effective vision. The Zernike coefficient has the same function. It will give you also a hint about the different aberrations and can get you an idea about how much is the patient is having aberrations. One of the methods to detect wavefront is actually the Hartman wavefront sensor. The idea of this is actually by shining a light into the eye, and we record the reflected wavefront. It will give us idea about the aberration of the whole optical system. What we mean by this, it will give you the aberrations of the cornea, the lens, and until it reaches to the retina and then reflected. This reflection of the wavefront will be recorded into a camera, then an image should be generated. This is exactly how it is generated at this area. So the wavefront aberrometry is like that. If you're having a perfect eye, then you should not give any aberration. But in most of the patients, there are some aberrations where it can be detected. So let's go back to this table where we said that we have a customized and we have non-customized way of ablation. The conventional and the Wavefront-optimized are not customized to a certain patient, but a Wavefront-guided and Topo-guided are customized to each patient. And we're going to speak about them. The conventional way of treatment, it takes only the patient refraction, the sphere and the cylinder. And it only can correct a low order aberration. So it has nothing with high order aberration. The problem of these kind of treatment profile is it can induce a certain level of high order aberrations, specifically spherical aberration, which will lead to, of course, reducing the contrast and halos and difficulties in night vision. Then the Wavefront-optimized treatment, which only again uses the patient refraction, it uses the wavefront to generate an additional laser pulses. These laser pulses will be applied on the periphery, the corneal periphery. And the aim of these pulses is to reduce the aberration that it used to be induced by the conventional treatment. So this will minimize the high order aberration, and that is actually was generated by the conventional treatment. And this will lead to a better quality vision, especially at night. A Wavefront-guided treatment, a little bit different. They are customized to each patient, and they use the wavefront scan to drive the ablation. And this will allow us to correct high order aberration as well as the low order aberration. But again, it can also induce sort of aberration that was not existing preoperatively. But the one point here is very important to mention, that the scan, the wavefront scan, is actually it was actually generated from the whole optical system aberration. What we mean by this, that it will take the cornea, the lens aberration in consideration whenever they treat by this profile. Of course, they need a registration, which will be required in order to deliver a very precise intended pattern of treatment. There must be a reference point in the iris to compensate for the cyclotorsion or a pupil shift. And the tracking system is here maintaining a good centration, and this will ensure a right delivery of the customized ablation profile. Topo-guided treatment is a little bit different. Topo-guided treatment will get the data generated by the topographer, and it will customize a treatment based on this topography. And this is usually, we use it in cases of highly apparated eyes, such as patients with RK or penetrating keratoplasty. Keep in mind, these aberrations are only corneal aberrations. It's not the whole optical system aberrations. This is only corneal aberrations. And this is the difference between topo-guided and wavefront-guided. Okay, so now we'll move and speak about patient evaluation. For any intervention, knowing the patient expectation and motivation is very crucial in order to address the need of the patient. So we need to assess the specific expectation, and then you need to discuss with the patient the uncorrected distance versus reading vision. In history taking, these are some of the points that I just need to stress on. You need to take care about the requirement of this procedure, why the patient actually wants to do these procedures. And this is one, as we said before. Second, we need to know what profession is the patient actually having or aiming to. And if they actually involve, for example, in a military service, if they are football players, it makes a huge difference in your decision making. And you need to know about the habits of the patients, use of tobacco. Medical history is very crucial. You need to elaborate from the patient more. If they are having diabetes, for example, connective tissue diseases, either they know or you ask them, because some of them they don't know. So we need to elaborate, you need to ask in detail so they will get it. And then you need to ask about what medications they're using, either topically or systemic medications. You need to know if they're using any medication that can alert your treatment, change of refraction, or some of the medication that induces a dry eye, which is quite common. Then you need to ask the patient about a contact lens use, because this will change the whole idea about your topography, about the accuracy of your refraction. And then you need also to elaborate history in keratoconus. You need to ask them about family history of keratoconus, any previous ocular procedures. And one of the things that can help you to ensure the stability of the refraction is asking about the change of glasses. Age is not the only factor that you should rely on stability of refraction. Yes, above the age of 18, they tend to have more stable refraction. At the age of 21, it's even more stable refraction. But this is not usually the case. You need to make sure that they're really having a stable refraction and they're not changing their glasses frequently. In your examination, you should take care and you should examine the patient very well. Uncorrected near and distance vision is mandatory. You need to know the manifest refraction. good if you know the ocular dominance and the monovision demonstration. You need to examine the pupil very well. You need to measure the size of the pupil. Of course, you need to check the mortality of the eye. Slit lamp examination is very crucial. During your examination, you need to evaluate the lid. You need to make sure there is no signs of infection, blepharitis. You need to flip the lid to check these patients are having any issues of allergy, for example, vacancy. And of course, you need to evaluate the pressure. A dry eye evaluation is very crucial in patients, in approaching patient for refractive surgery. You need to examine them. You need to do all the required tests to elaborate more about dry eye. Corneal topography is a very crucial. It is very important, and it is a cornerstone of any evaluation for refractive surgery. Sometimes we ask for a wavefront analysis. It's not for every patient, but some of the patient. For example, if the patient came to your clinic and asking for refractive surgery, and they also they tell you that they're having a problem during nighttime driving. So this might give you that they have already an aberration that you need to tackle. So here comes the wavefront maps and analysis, which will give you a lot of hints and idea. Pachymetry is important. Cycloplegic refraction is important, especially in cases of hyperopia. There is a debate that it should be done for every single patient. And but keep it in mind if you're dealing with the case of hyperopia, or you're not happy about the refraction of the patient, or you're seeing the patient with a different visits and you're seeing instability refraction with a stable topography, it might help you. Dilated fundus examination for optic nerve, macula, and periphery, especially most of those patients are myopic, and you need to check the retinal periphery very carefully. Whenever you approach a patient for refractive surgery, in your history, in your examination, keep in mind the contraindication. For example, in history taking, as we mentioned, you should take care about the connective tissue diseases in your evaluation clinically, and by investigation, you need to take care if they don't have any ectatic disorder. You need to see if there is any dystrophies, diabetic retinopathy, dry eye syndrome, focus endothelial dystrophies. If the patient is having a neurotrophic corneas, ladies who are pregnant or breastfeeding, patients with unreasonable expectations, patients who are young, and if there is any previous history of infection, herpes simplex or herpes zoster. And if the patient is having thyroid eye diseases or uncontrolled diabetes. This table is from the academy. I'm sure that all of you came across this table. But while you are evaluating the patient, just keep these contraindication in mind. It will guide you a lot. Okay, now we're going to speak about some of the calculation. These calculations, as I said, it can help you quickly to evaluate if the patient fits for refractive surgery or not. A depth of ablation, it's a little bit different from surface treatment or LASIK, but the general rule of calculating the depth is by multiplying the power by the optical zone diameter to the power of 2, then you divide them by 3. Generally speaking, the residual bit thickness should not go in LASIK below 250. In PRK, most of the practitioner, most of the references are telling classic teaching should not go below 400. Nowadays, a little bit lower than that, but not lower than 370. This is not a cut-off number, but just an idea. Okay. In calculating any patient if you're checking the thickness, the epithelium is more or less around 50 microns. And if you are in doubt, you can get an epithelial map, which would give you an idea. And it is very precise with the new OCT machines. Generally speaking, whenever you're correcting one diopter of a sphere, it takes around from 14 to 17 microns. This specifically is actually related to the optical zone. Generally speaking, and just for the sake of evaluation, you can use the average of 15 microns for each diopter to give you an idea about the thickness and the remaining thickness. If you're having sphere and cylinder, like a patient with a myopia and astigmatism, then you need to get the sum of both refractive errors. Okay, both of them. For example, if the patient is having -4 of myopia and 3 diopter of cylinder, then your calculation should be 7 diopters of refractive error to calculate how much each diopter will take. And if you're having a mixed astigmatism, then the equation should be converted to a plus formula, then you do it. The K reading in a myopic patient, you need to look at the flat K. Then the correction of each diopter, it reduces the flat K by around 0.775 diopter. So the final flat K should be according to the amount of myopic ablation. And this should not go down less than 34, okay? In a hyperopic patient, the hyperopic ablation, we need to look at the steep K. Each one diopter of hyperopia will increase the steepest K by 1.2 diopters. And the final steep K, according to the amount of hyperopic ablation, this should not exceed 49. This limitation between 49 and 34 is actually for the sake of having good quality of vision. If you exceed these numbers, you might get into a poor visual quality, more aberrations. And this will reduce the best corrected visual acuity, which is a bit serious. Pupil size and optical zone. We actually measure the pupil size in photopic and scotopic conditions in order to select an optical zone. The optical zone, generally speaking, should be larger than the pupil diameter. And the reason is to minimize the disturbance from the aberrations. And this actually should be customized. What I mean is, should be customized to every patient based on the pupil size, based on their actual preoperative visual disturbance and their profession. If they're a driver, then you might consider a larger optical zone. But also this depends on the ablation profile and the level of refractive error. Sometimes it is limited by the thickness, and sometimes it is limited by high refractive error. Last part is the angle kappa, which is the angle between the visual axis and the pupillary axis. It is considered to be significant whenever it exceeds 0.1 millimeter, around 100 micron. Whenever you get this large angle kappa, you need to exclude the misalignment. So you need to repeat again the test. And if it's really a large angle kappa, then in these cases, you need to have a different ablation profile, which is a different story. Okay, this is all what I have. And inshallah, I'm planning to give you another lecture, another subspecialty lecture and we're going to speak about complication of refractive surgeries. And then we can compare the different type of refractive surgeries as per the complication, as per the patient's requirement, and then we will have a comprehensive view about the different type and different procedures of refractive surgery. These are my references, and now it is the time to have any question. I'll be more than happy to answer. I got a question here from one of our colleagues asking about the residual stromal bit in astigmatism, whether we use a spherical equivalent or not. Actually, this is an area of debate. Sometimes it is safer to use the sum of both. What I mean, that you take the sphere and you take the cylinder and you sum them together. Like I gave you the example of 4 diopter of myopia and 3 diopter of astigmatism. You calculate them as 7. You don't take the spherical equivalent. This is a bit more conservative approach, more safe approach, compared to if you take the spherical equivalent. And I ask a lot of people about this specific point, and all of them, they agree that they take the absolute sum of both instead of the spherical equivalent. And this is a bit more safer approach. The other question is, what is the difference between SMILE and LASIK? LASIK is actually, we make a flap, we elevate the flap, we apply the Excimer laser, and we put the flap back. In SMILE, it's a bit different story. We remove part of the cornea. We use a femtosecond laser to remove a lenticule, part of the cornea, and then we ablate. But in LASIK, we don't remove anything. We keep it as it is. And this is what I'm planning to do, inshallah. The next lecture, I'll be speaking about the complication. And then I'm going to compare both procedures, which is better, which one is suitable to which different of patients. But this comparison, it will be more beneficial after we do the second part. The other question, LASIK allow a lesser bit, stromal bit residual compared to PRK. Actually, PRK, one of the indications of a PRK is actually thin cornea. We use it whenever we're having a thin cornea. Because, and LASIK, and more or less, we're making a flap of 120 microns, and then we do the laser under this flap, okay? And if we are limited by the corneal thickness, we go for PRK, which gives us a little bit more room to do the LASIK, the Excimer laser. The other question is, pregnant lady would still proceed for refractive surgery. It is a relative contraindication as per the American Academy of Ophthalmology, because the hormonal changes will lead to a difference in refraction. And it might give you wrong measurements. That's why we don't do it. I have another question now about the thinnest location for PRK. As I said, classic teachings is 400 microns. Some people are going a little bit lower than that, up to 300 370, 350, but it is all based on the specific topography, the need of or possibility, for example, of ectasia. These are the factors that we keep in consideration whenever we consider thickness. But it is very crucial to take care of the thickness in the pre-operative evaluation. Safer approach, conservative approach is 400 microns in PRK. Another question. Speaking about if the refractive surgery is becoming less invasive, why should we care about dry eye? The reason we take care of dry eye, first of all, we need to address if the patient is having dry eye or not. That's the first thing. Okay, this is number one. And we need to treat, we need to understand why these patients are having dry eye. If it's related to mammalian gland problem, exposure, medications. So we need to treat this first. And most of the time, we either defer the refractive procedures or we don't do it at all if the patient is having a dry eye. And the reason is refractive surgery in general, it induces more dry eye. LASIK is known to have more dry eye compared to PRK. And the reason is that in LASIK flap creation, it cuts the corneal nerves. So the sensation will be less. The chances of development of a dry eye becomes more. That's why we don't do it. I think this is it. I'm not sure if we have any more questions. If you have any more questions, I'll be more than happy to answer. You will find me everywhere. And I hope that I delivered the message that I wanted to deliver, which is just the concepts. I see some of our colleagues are getting confused by these concepts. So that's why I actually intended to do this clarification. And this is another question: how can we deal with aberrations? The newer machines, it tend to induce less compared to the old machines. This is what I know. And most of the time, if the patient is having already aberrations, that it might be worse after the procedure. So this is why we tend to look at these patients and customize their treatment based on their perioperative wavefront aberrations. So this is why we actually take care of these aberrations. The idea of doing this is actually getting into a perfect level of vision. Is not treating lower order aberrations and jeopardizing the vision with high order aberrations. We need to know first if the patient is really having an aberrations or not. If not, then we will proceed with the surgery. And as I told you, most of the time we don't need them, but sometimes we do. Another school or another indications, whenever we're dealing with, for example, a patient post-keratoplasty, and they really suffer from a lot of aberrations. Sometimes we correct them with the glasses, and they can see good 20/20, 20/25, but they're not happy because the aberrations are really significant. They cannot drive at night. They cannot really enjoy good night vision. Another question about if the patient is going for cataract surgery, whether these issues will tackle them. The issue now is, as I said, sometimes aberration comes from the lens. And if you're going for only refractive procedures, you don't know whether these aberrations are coming from the cornea or coming from the lens. So we need to understand which is which. That's one. Second, it should not affect patients, but the problem of cataract surgery in these patients is actually calculation, which is more significant. I mean, IOL calculation for them. This is another question. If the patient with residual bit thickness is less than 50 of the corneal thickness, but is still above 250. Yes, there is actually there is a rule for this. Whether is it 50% of the thickness or it is above 250. Generally speaking, there is a rule that should not be less than 250, but it should not exceed this number. Okay, if it's less than 50% of the corneal thickness and above, this is safe sometimes to go, but you need to exactly to know. Dr. Mazen Sanjab in his series, which is I really recommend everybody to watch. It's a very good and very simplified way of explanation. He had a rule for this, and he specified if you are getting into this dilemma, which one to go for, the thickness or the percentage. From what I see, people are depending on the thickness more, but also this is another important point to look at. And if you don't have any question, we can take 5 minutes break before Dr. Noura Khareji starts. And inshallah, we'll see you in the next lecture. And I hope, inshallah, it will be more fun than this lecture. Good luck, and it was a pleasure seeing you.